All right, welcome back, everyone. So first, I would like to welcome Dr. Hashem Serag, a professor and chair of the Department of Medicine at Baylor College of Medicine in Houston. Dr. Serag completed his residency in internal medicine at Yale University and completed a fellowship in clinical gastroenterology at the University of New Mexico, where he also earned a master's degree in public health. He has obtained more than 50 funded research grants, has more than 450 published papers, and has served on multiple national leadership roles, including editor-in-chief for clinical gastroenterology and hepatology. Dr. Serag's research focuses on the clinical epidemiology and outcomes of several digestive disorders, hepatocellular carcinoma, and hepatitis C. So welcome.
Thank you very much for the introduction. Thank you for inviting me, Dr. Feld and Shukri and Lamar. Appreciate this. As you can tell by my name and my accent, I'm actually from Texas. I'm glad you're awake after lunch. That's fantastic. This starts a session that is admittedly a lot more concrete than the morning discussions, and it deals with a narrow topic. It's what happens after you cure hepatitis C. I will first submit that the major gap is everything that was dealt with during this morning. You need to reach more people, treat them, etc., etc. But this assumes that you've done that. So why is the issue topical and important? Hepatocellular carcinoma is one of the few causes of cancer that continue to increase in the face of a universal decrease in the burden of cancer in North America. This is United States, but we do consider you as part of North America. So, and I believe liver cancer is rising in Canada too. So I'm going to take you to hepatitis C in the wild, as I call it, active hepatitis C, untreated hepatitis C. It used to be the most virulent risk factor for hepatocellular carcinoma. So those who have it have a 25-fold at least increase in the risk of developing hepatocellular carcinoma compared to those who don't. Astronomical odds ratios as things go. The absolute risk is not too little anyway. 1 in 100 of all comers would develop it if they stay with it for at least 30 years. But then if you get to that stage of cirrhosis of the liver, then the risks are really astronomical by any measure. 3.5% per year. And estimates are as high as 7% per year is the risk of hepatocellular carcinoma in hepatitis C that is untreated. That pertains to all of your morning discussions. This has the other thing I want to anchor here is I will be talking numbers. I'm an epidemiologist, but I want to show you why those numbers are important. Because of the very bottom line on this slide, clinical guidelines recommend surveillance for hepatocellular carcinoma among those whose annual risk of HCC exceeds 1.5%. In some other estimates, it's 1%. What does that mean? It means even if you cure people and the risk remains higher than that magic number, they're not out of the woods. You have to keep them under some sort of a surveillance. That is really the most important number, 1% per year. So if you forget everything, any person, 1% per year, more than that, then they have to be under some sort of an intense surveillance if you believe in that. Okay. So the third important message is, and again, lending credence to the importance of the morning attempts, is among those who develop cirrhosis, there seems to be an irreversible increase in hepatocellular carcinoma. So catching them early before they develop cirrhosis and curing them is crucial. So there will be on and on and on and on in my talk mentioning the word cirrhosis as one of those things where the cat is somewhat out of the bag. There used to be a time when I would spend 20 minutes, I actually never finished a talk in 20 minutes, so it must have been longer than that, where I would talk the whole thing about what makes someone with hepatitis C develop hepatocellular carcinoma. And I would go into each one of those risk factors in a classic epidemiology sense. Fortunately or unfortunately, that slide is almost completely null and void. In modern practice, there's only one risk factor for hepatocellular carcinoma among those with hepatitis C. Did they get treated and did they get cure? SVR, sustained virological response, which is virological cure or not. In the presence of that variable, it trumps, no pun intended here, almost any other factor that is mentioned on those slides. The epidemiology, if you will, of HCC and HCV has been completely rewritten. So there have been many studies that are observational, retrospective, that looked at what happens to the risk of HCC among those with hepatitis C who get treated with the new fancy medications. New fancy medications, DA, directly acting antiretroviral. I'm going to present the best of them because it's ours, but there are 10 of it, 10 similar studies. So this study uses the National VA database in the US, which capture information from close to 130 hospitals, very large number of patients with hepatitis C. As you can see, 23,000 plus. We excluded those who had hepatocellular carcinoma at baseline, left us with still a very large number. These new medications work almost all the time meaning 90%. That's why you end up with 19,500 plus who got cured. And because these are large numbers, even a 10% proportion results in almost 3,000 who did not achieve SVR. And then we follow them longitudinally, and you see 183 cases developed in the group that was cured and 88 in the group that was not cured. So a couple of important findings. While my talk would focus exclusively on the residual risk of hepatocellular carcinoma, the benefit is overwhelming. So the red line, you don't need to be a statistician to tell, it's much higher than the blue line. So message number one, those who get cured have a significant drop in the risk of developing hepatocellular carcinoma in a relatively short time. The x-axis is months, not years. So message number one. Message number two, and that's the bad news, the blue line does not go back to flat line. In other words, those who get cured still develop cancer. So who are those unfortunate few that you catch, diagnose, treat, cure, and then they develop cancer after that? How unlucky do you have to be? And the answer is cirrhosis. So our study hypothesis, that is cirrhosis. So we stratified the analysis by cirrhosis. The x-axis indicates the annual risk. Remember that number? 1%, 1.5%. So if you look at those with cirrhosis, the annual risk of developing HCC after curing hepatitis C is 1.8%. So clearly higher than what guidelines still recommend keeping people in surveillance. Remember my second message? The epidemiology has to be rewritten. Look at those red dots. They're aligned almost the same, which means it doesn't matter. If they drink alcohol, they use drugs, they old, young, etc. The good news of this slide is the without cirrhosis. So those who are cured without having the lesion cirrhosis, their annual risk is really, really low. Just go down to the x-axis. We're talking 0.2%. Clearly much lower than any guideline would recommend a high-risk group. One exception is the very last line. There's something called FIB4. It's a non-invasive measure of the amount of scarring or fibrosis in the liver. And those who are scarred close enough to be cirrhotics, the risk is high. After those multiple retrospective studies have really shown that case, I'd be remiss not to show the only prospective cohort study, a multi-center, multi-country European study that was published, of course, in The Lancet, while the rest of our papers were not in The Lancet. But this showed exactly the same thing that the retrospective studies have shown. One graph shows the all-cause mortality. The other graph shows the hepatocellular carcinoma. Whichever the bad of those two lines indicate those who did not cure. So Message: hepatocellular carcinoma risk reduction is significant among those who get treated and get cured. To put it visually better, if you think of the world as 2x2 tables, there are 4 groups that may happen after treating someone with hepatitis C. The worst group is having cirrhosis and not getting cured. That's the bottom line. That's the highest risk of liver cancer. The best group is having no cirrhosis and getting cured. That's the high line, almost no cancer. And the other 2 groups are somewhere in between. That's as simple as you can tell the epidemiology of HCC in Hep C nowadays. So among patients treated with DAA, SVR results in considerable reduction. SVR itself, as opposed to the agent itself or the type of the DAA, or for that matter, even interferon, would result almost in the same amount of risk reduction. However, the absolute risk remains high in the approximately 30 to 40% who are unfortunate enough to have already developed cirrhosis. And that annual risk ranges anywhere between 1.5% to 7%, which means this group, at least clinically, needs to be surveyed. And clinicians should take that into account. So the story was relatively uncomplicated. And here, this is sort of, perhaps the next 2 slides are for the diehard. In other words, hepatologists, transplant people. If you don't belong to that, you could check your email. So a group from Barcelona who deals with treating hepatocellular carcinoma looked at a group of people who already had cancer, received whatever people give to cancer that is not cured, which is ablation and things like that. And then they had hepatitis C too. They treated them, they cured them, and then they reported in a group of 50 people that they witnessed, quote unquote, an unusual high rate of recurrence in an uncontrolled small observational studies. So they saw recurrence of HCC among those who already had HCC, 27% over a median follow-up of 5.7 months, and the median time from HCC treatment to initiation was close to a year, and the median time from DA initiation to HCC was quite short. So there was an alarm signal from an observational uncontrolled study. There could be a bad effect for hepatitis C treatment in those who already developed cancer and got treated. So really, really bad study design. Fortunately, a slew of equally bad design studies did not confirm the same finding until a slightly better design study, multi-center studies, observational, still larger number of patients, 300 or so DEA treated, a large number that was not DEA treated, decent amount of follow-up. And what it shows here, the 2 lines that are virtually superimposed, is the risk of recurrence among those who received DAA and those who did not receive DAA. 2 types of analyses. You don't need to bother about them, but basically they stack the odds against DAA treatment. That shows no significant recurrence of HCC among those who are treated for hepatitis C. So if you love meta-analysis, you get a kick out of this one. It just shows everything I said and puts some numbers around it and confidence intervals. And the bottom line from this meta-analysis, which is slightly outdated by now, is both de novo risk of HCC as well as recurrent risk of HCC is significantly reduced with treatment that is successful for hepatitis C. So that is all good. So summary number 2, again, this is for the diehard. Overall data do not support an increase in HCC recurrence with DAA treatment. The early recurrence after DAA is likely incompletely cured HCC, which many of us thought this might be the case. So what would you do if you're a clinician who deals with that subgroup? I think it's prudent to consider treating hepatitis C, but if you're going to do it, I would wait 6 months just to make sure that the cancer is actually under control before you embark on such treatment, and then you monitor them closely. So Dr. Feld is the person who invited me, so I'd be remiss not to put some more sophisticated spin on my talk. So far, it's very crude. Just treat them. If they're not cirrhotics, they'll be fine. If they're cirrhotic, they're not fine. But there could be another way. So everything I mentioned is in the top part of this diagram, which is hepatitis C leads to inflammation, leads to scarring, leads to cirrhosis. That elevates the risk of hepatocellular carcinoma. However, hepatitis C also results in changes in the immunology and interferon-stimulated gene induction. And after a long time of changes in the immunology, some of those immunological changes are not completely reversed, and therefore they may explain some of the residual risk of cancer. That's conceptually. Not so conceptually, the immunology of acute and chronic hepatitis C has been previously examined, and what it shows that in steady state, in chronic hepatitis C infection, there is a level of a virus that is detectable. There are type 1 and 3 interferons that are high. They're supposed to help clearing, but they don't. And then there is paucity of T-cell lymphocytes, the so-called mucosal-associated inadvertent T-cells, and low levels of interferon gamma. Interferon. So basically, there are profound immunological changes. Some of it is failed immunology, some of it is adaptive immunology. What happens after treatment? I'm going to summarize that many of the immunological features of chronic infection gets ameliorated with successful treatment, but notable few exceptions remain. One of them, those ISG, interferon-stimulated genes and associated cytokines, while decline, they remain elevated, and that elevation has been shown in small studies to be higher among those who develop HCC compared to those who don't. CD8 T cells, those are the mate that I talked about. These are the ones that are preferentially proliferate in the liver, and they're depleted in chronic hepatitis C infection, are restored, but not completely. And these things help in the restoration of immunity as well as in immune surveillance. And therefore, this immunology story may explain some of the residual effects of hepatocellular carcinoma. If you need any other questions, ask Dr. Feld, not me. So to affirm the story in the morning, despite this amazing success in treatment, virtually anyone who shows up to a hepatology clinic nowadays gets cured. It's really amazing. In my lifetime, my clinic has changed to 100% uncured hep C in the clinic to 100% no hepatitis C. It's dramatic. You would think that hepatitis C is gone. But despite that, hepatitis C, those are proportions, remains the leading etiology underlying hepatocellular carcinoma in North America. What does that mean? It means most of them are not detected and not treated. Nevertheless, this dramatic success of treatment has started, I think, finally dropping the total burden of HCV-related HCC. And this is what the new frontier now, and I'm almost now at the conclusion of my talk, and this is a classic epi talk. I used to show it to show that while hepatitis C in the second line is not common, I mean, all this hoopla in the morning about 1 to 2%. I say that in just because unless you're one of them, it's not a big deal. So 1 to 2%, but it's highly virulent when it's active. It's 20 to 25-fold. So it accounted for 25% of the total population burden. But what happens now, once you suppress it, once you get rid of the virus actively, the actual relative risk plummets. So now we're dealing, hopefully, with a lower burden of hepatitis C related HCC, and that's the good news. The bad news, if you're a clinician, you will have more and more patients who are not completely risk-free, who you're just looking at them, and what used to be an easy counseling for the amount of risk is no longer easy. So between hepatitis C that is completely treated, hepatitis B that is adequately suppressed, and non-alcoholic fatty liver disease, clinicians have really a nightmarish job to determine what to do with those patients and how to stratify the risk of HCC. So there will be a lot of work that needs to be done in that area. Over time, regression is likely, and therefore some of the things that I mentioned early on might actually improve. So maybe in 10 years, I'll come and tell you if you cure them and they remain alive for 10 years, what used to be a high risk of HCC will diminish. And both us and others are trying to form so-called risk stratification models among those who are cured. One of them is HES, my initials, by the way. Completely coincidental, knowing that the group who did the work is ours. So it uses simple biomarkers, AFP. AFP changes over time, concurrent ALT and platelets, puts it in a model, and that gives you a decent stratification magnitudes. There's a so-called GALAD, and you can see it here if you need to splurge and spend money. And lastly, people are now thinking of combining multiple factors such as age, platelet count, AFP, albumin, and AST and ALT to enable us to say something slightly more intelligent than what I said early, which is do they have cirrhosis or not, to determine the risk of HCC among those cured of Hep C. So in conclusion, for HCV, DEA-related SVR reduces both the risk of de novo and possibly, and I would say for sure now, recurrent HCC. There's a change in HCC risk in HCV. I guess I'm confusing you completely. There is lower individual risk, but more individuals at risk. Does that make sense? Okay, you'll be curing lots of people. They'll be accumulating in your clinics. Their individual risk on a one-to-one basis is much lower than before. And for that residual HCC risk, I discussed some of the risk factors and the mechanisms, and stratification remains an unmet need. Thank you.